For disclosures, I have to disclose that I'm a surgeon, and sadly, I have no financial disclosures. So what are we going to talk about today? Well, I'm going to outline a little bit of the physiology and why doing a liver transplant makes sense in propionic acidemia. I'm going to talk a little bit about the technical aspects of liver transplant. I'm going to really go over some of the challenges about that, and I'm going to describe the children's hospital experience. And you'll understand why all of the experiences and all of the experience in liver transplant may be different in different places, and for a few different reasons. So let's start. I don't have to tell you what propionic acidemia is. In fact, the talks that were prior to mine really made my life easy. So thank you for the speakers. It really is just a single genetic problem whereby patients don't have a single enzyme that is functioning in their bodies, and it's important to understand that enzyme is throughout the entire body. And in cases of propionic acidemia, it's missing in the entire body, not just in the liver. The liver is a privileged spot, and so the liver does really, it's the primary spot where the main substrate of this enzyme is broken down. But again, it's the enzyme is throughout the entire body, and in these cases, it is not. And so that's what the problem is. And so what are the manifestations? Thank God we got the same percentage. Cardiac manifestations, about 25%, certainly more, and it depends on how you look. And Dr. Venditti talked a little bit about natural history studies, and if you really looked at everybody with PA, you would probably find that there's more cardiac manifestations than in the general population, because you don't get symptomatic from these until it's relatively far along. And the other thing is that some of the symptoms are things like arrhythmias, and you don't actually have a real problem with that. The cardiac manifestations, it's in evolution as to how and to why this disease affects your heart. And likewise, it's unknown if that would get better with treatment or would advance with treatment. And we'll talk a little bit about the studies with liver transplant and cardiac disease and other diseases that highlight that. What else? Well, neurologic manifestations. In studies and in larger studies of liver transplant, it seems that they are related to metabolic decompensations, and patients who have fewer decompensations have better neurologic outcomes. But again, a very small number of patients, very small population, and so that may also be due to the fact that there's enzyme in your brain that is missing, and it's not just how well controlled you are, but it may be that indeed the enzyme that is not working in your brain, regardless of what your peripheral control is, could cause issues in the future. And so, what else do you see? Well, pancreatitis is something that, and the cousin disease to PA is MMA. And so I think that there's a lot of crossover and a lot of research in one that's with the other. And in fact, a lot of the liver transplant studies group them together and say, well, this is our experience with organic acidemias. And but I think that, if you said pancreatitis, it's more of a MMA disease. Renal dysfunction, without question, is seen in propionic acidemia. We've seen it after liver transplant with propionic acidemia, but it's certainly, if you were taking a board in metabolic genetics, you would say that's an MMA kind of thing. The others are relatively rare and even less well described. And so immunologic effects, unknown. And so there have been patients, and there have been reports of patients that have things like immune dysregulations with propionic acidemia. So there's been reports of a child who had crisis, who developed another disease called HLH, which is kind of it's a disease whereby your body starts to destroy your own blood cells. And so there may be some immune dysregulation. It's not something that, believe it or not, after liver transplant we have seen much of, even though we alter immune systems relatively dramatically. near and dear to my heart. There's no question that PA affects your liver as you get older. The liver is not normal when we do transplants for PA on adults. The livers are they're large. They oftentimes function relatively normally, but there's low levels of enzymes that we see in the blood that are elevated, and the livers grossly are larger than normal. And so, what do we have for non-transplant therapy? Well, we've heard it all, and you're living it. If you have PA, then you're doing all of these things, and we discussed just now, treatments for the future. And so, gene therapy is certainly a treatment for the future, and it's something that is up and coming. And so that I would put into the other category. All right, let's talk about liver transplant. And so because that's what I do, and I feel like I should talk about it. I'll talk about what I want. No. And so liver transplant really, when you talk about the data saying liver transplant is curative in propionic acidemia, that's not really the case. And just like gene therapy, liver transplant is something that treats the disease. It certainly does not cure it. And you are essentially doing an enzyme replacement. And so if you were able to, instead of doing a liver transplant, have a bag of the enzyme and put it into your bloodstream, and somehow make that work, it would be the same thing. So a liver transplant does not fix the brain. The liver transplant does not fix the heart. It doesn't send enzyme to the heart. It doesn't send all of those things. But what liver transplant, does do is that it fixes the metabolism. It helps the metabolism in the body, and it helps the blood levels, and it helps kind of the underlying. And so we're talking about independent areas and cellular independence. It fixes the bloodstream, and it fixes that type of issue. But again, it is not a treatment that goes all over your body. And so this is the enzyme pathway that it fixes there. So when we talk about levels, you can see here after liver transplant, these are patients who have had liver transplants. There's things that you measure in the blood for propionic acidemia, and there are better markers without a question. And these are just more levels. And so as a person that has the disease, as a family, you say, well, great, that means it fixes it. And we've been through this already in the last two talks. It doesn't totally fix it. And so I can help the levels, I can help your enzyme activity, but by no means is it making this completely normal. And these are levels that are done after liver transplant. These are levels that are done on restricted diet. And so let me talk about a little bit about liver transplant. Anybody squeamish? No. Okay, good. So what's involved in liver transplant? My first foray into artificial intelligence was this diagram. I asked ChatGPT to make me a diagram of things involved in a liver transplant. And you can count the typos, but I think it's a beautiful graphic, which is very impressive. But it's this like donor and stuff like that up there. But it's actually an interesting thing. I had never used it before, but I figured I'd introduce it here. And so what's involved? Well, so before we even think about liver transplant in a patient, regardless of their underlying disease, we have to see them and figure out whether the liver transplant is indicated. And so I think that if you're coming from a clinic, if you're coming from a place where you have the disease, we know the mutation, we know the disease, you've been followed by patients, and the metabolic geneticists and the metabolic folks say, hey, a liver transplant's indicated, then I think that first kind of step is done. I mean, I think that, nobody knows the difficulties, and nobody knows the ability to treat this disease better than the folks that are treating you. And so that's step one. The next thing that we have to do is figure out if a liver transplant is dangerous. And so it gives you, just like anything else, just like gene therapy, it gives you a risk to benefit ratio. And I can tell you the benefit, and we can I'll go over the kind of the world's literature on transplant for PA and our results. But that's the benefit side. But what's the risk? And so the easy way to think about it is, hey, what's the risk of a transplant in general? We'll talk about that. What's the risk of a transplant in someone with PA? Well, if they have underlying cardiac disease, Is their cardiac disease so bad that a liver transplant, they wouldn't survive a liver transplant? Or is their cardiac disease so bad that they need a heart and a liver transplant? And so that's all part of the evaluation. When you come, we evaluate your renal function, evaluate basically every other system to say, is there anything else that we have to worry about in addition to the liver transplant thing, to worry about to get you through the transplant? At the end of all that, we sit down, we talk as a group, so everybody that has seen you, including the doctors that have referred you oftentimes, and then we call and we talk to you, and it's really a decision, and it's one of the few decisions that is openly kind of multidisciplinary and involving the family. And you say, hey, this is what we found in your evaluation. We think this is the risk, and is it something that you want to press forward with? And if at the time of evaluation, you learn a lot about liver transplant, much more than I'm going to cover in 2 slides. And so you learn a lot, and you learn a lot about the risks of just regular liver transplant in the setting of not propionic acidemia, and this just in the setting of a liver transplant. Next step, we put you on the list. That's very easy to do. It's a couple of clicks of buttons. After that is the waiting time. And so there's many different sources of livers, and I'll tell you a little bit about our experience with where we get livers. Sounds weird, right? But who are the donors? And then the time of transplant, you would come to Pittsburgh. You have about 6 to 8 hours to get there. We talk to you about the donor. We say, hey, we have a potential donor liver for you. It seems to be good size. We talk about the social history of the donor. We talk about any blood work in the donor that would be risky, and that also kind of factors into the risk. And so it's not just the risk of the procedure, but the donor also, there's specific things with the donor that you have to know about. And so we go over all of that, and if everyone agrees, then we would press forward, and that's when my step comes in, and we just do the liver transplant. And then after the transplant, general stay in the hospital is about 20 something days, and general stay in Pittsburgh is usually about 3 months. I think that the stay in Pittsburgh and is more dependent on your doctors at home and your ability to be followed at home. And so, your ability to get blood work, your ability to kind of do that type of thing. If you're at a center that we don't know, if you're with doctors that we don't know, it's much harder to get you home. It's a little easier when you have the doctors in your cell phone. And then we'll talk a little bit about long-term immunosuppression and some of that risk. What are the livers that we use for liver transplant? Well, in the United States in 2024, if you were a child waiting for a liver from a child, you would never get a liver transplant. And so there's just, and it's when I say that, I don't mean that it's a bad thing. It's a good thing because it means that children in the United States are not dying of brain injuries. They're not dying of things that are preventable. And I think that, it's a good thing, but there's just not enough children donors to supply all of the need. There's about 500 pediatric liver transplants done in the United States every year. It's a pretty consistent number. Of the number of those that are done that are parts of adult, it's more than half. And that's around the country. It's more in different centers. So less than half of pediatric liver transplants are done using a pediatric organ. So the type of liver that your child would get is usually the one on your on the right. It's the left lateral segment. It's the smallest piece of the liver, and it's from an adult to a child. The size is actually perfect. And so, what's the whole process look like? Well, you after you get called in, we accept the organ, we make sure that you're not sick. You come, everyone seems to be good. I get on that little plane, we fly off, and that's an adult liver. You can see the left portion is the portion that you get as a child. Keep going, you do an x-ray, make sure the bile ducts, which are the things inside the liver, look okay. You can't see those from the outside. And if they look okay, we take the liver and we start to split it. And you can see we split the liver into a small little piece for a child and a large piece on the right for an adult. And so one adult liver in general can go to 2 people, 1 adult and one child. that's the incision. This is kind of a normal everyday size child that got a left lateral segment, and that's the incision. That's what everyone wants to know about. Those two little things coming off on the right side are drains, and they just let us know if there's anything in the belly, like blood or bile, that would prompt us to go back to the operating room. They usually stay in your belly for about a week after, and they just come out at the bedside. There's not a separate surgery or anything. So that was a completely easy review of liver transplant right there. So let me talk a little bit about risks of liver transplant in general. If you said what is the survival of liver transplant in the United States for a child, is about 95%, I would say, and that's 5-year survival. So that's all comers, that's all diseases. And so some diseases are much harder to transplant. Some diseases, children have cancer. Some diseases, they're very sick to start. And so the patients that are sicker, that can have recurrent disease, patients that can have tumors that come back, they are the ones that more likely will not survive long-term after transplant. When you say, well, what's the longer term survival? What's the 10-year survival, the 15-year survival? Well, fortunately, it doesn't drop much. And so the initial drop off are things like kids who have tumors that come back, kids who have operative complications, but the overall survival at the end, and this is in Children's of Pittsburgh, the overall survival I think that bottom number is 140 at 140 months is about 90%, and that's again all diseases, all comers. I think this slide is about 5 years old. I think I had to go back about 7 or 10 presentations to find this. So it's probably about 5 years old. When we talk about organ survival, we talk about half-lives. And what is a half-life? Well, half-life is when half of the organs that you've put in are no longer working. And so if you said I did 100 liver transplants and we followed those patients for X number of years, at what year only half of them still working? And so an adult liver transplant, the half-life is somewhere about 15 to 20 years. And so that's really, good survival. It's less for things like pediatric kidney transplant, adult kidney transplant, where the half-life, there's half of those organs are no longer working or the patients are dead. The half-life there is about 7 to 10 years. And so the kidneys are worse. Good news is pediatric liver transplant, we don't have a half-life yet. And so that's data from back from 1989 is when UNOS kind of started collecting their data. And so right now, almost 70-something% of the livers that were put in are still there. And so we're not really close to a half-life yet. And so I comfortably say to the patients, the liver should be once. It's not something that without complication, without something else, the liver should be yours for life. We utilize livers that are young for that reason, and it's not something that you would want to do more than once in your life. Now, do patients need retransplants? No question. But those are not, those are patients that would have complications. Those are patients that have bad rejections. And the retransplant rate's about 5% in Pittsburgh. And so, somewhere thereabouts. Now, what about the complications? Well, biliary complications are common. And so bile ducts where the liver makes bile, that bile comes out, it goes through a small tube and it empties into your intestine. Where we attach the bile duct to the intestine can narrow. That happens about 15% of the time. The majority of those patients don't need a second operation. You can fix that problem with radiology. And so you go to, just like you would do a cardiac catheterization, you go to the radiology suite, go to sleep. They put a catheter into your liver and they balloon open this thing and they put a stent in. And so it's very similar in that aspect. And so about 85% of the time you get a bile duct complication, it can be handled without reoperating, which is great. Hepatic artery thrombosis was a real problem early in the experience of transplant. And so that's something that it used to be about 10% and it still is in some places. But I would say that, in a center that performs a lot of transplants, it should be between 1% and 3%, which is about right. And the same with portal vein, which is the other blood vessel that goes in. Bowel obstructions, anytime you do a liver transplant, every time you do a surgery on someone's abdomen, you get scarring. And so those scars can cause bowel obstructions. And I think that's, it's one of those things that happens. Even kids that just have appendixes taken out, that type of thing, you can end up with bowel obstructions. So that happens about 1% of the time. It seems about every year. We get one in our series of patients who has a bowel obstruction and needs an exploration. So that's kind of the usual kind of run-of-the-mill complications that we see. Now, something you have to understand, though, and this becomes very important when we analyze the data about transplant for propionic acidemia, is that not all centers are the same. And so I think that these two graphs are patient and graft survival in centers in the United States. And so the differentiating number of transplants between the top line and the bottom line, you want to be on the top line, is only about 5 transplants a year. Now, it means basically centers that do more transplants have better survival. And it makes sense, but it has never really been shown. And so the United Network for Organ Sharing, which are the people that allocate organs, actually put this data out. And it changed some of the things that you do, but patients in different centers do differently. And so that is it's an unfortunate consequence of having a country where there's a bunch of centers, about 50 something pediatric liver transplant centers that are doing liver transplants. And so it's important to understand that the data in patients with PA is a little bit skewed because there's small data, there's small numbers. And in addition to that, it's not the same center that's doing it. And so your result of a liver transplant with propionic acidemia at one place may not be the same as the other. And that's not something that you can kind of take out of a study. And so center effects, yes, every center gets complications. If you do a liver transplant, I guarantee if you do enough, not even enough, if you do 10 pediatric liver transplants, you're going to get a complication somewhere along the line. There's just no way to avoid that. But the dramatic flux in major complications like hepatic artery thrombosis is seen here. And these are centers that are in the United States and you can see the different rates of complications, which is enormous. And so, you don't want a hepatic artery thrombosis rate of 30, 40, 50%. And so, in 2024 in the United States, you wouldn't think that this graph would exist, but it does. And then what you do with your complication is also important. And so if some centers are much better treating complications than others. And so this graph kind of shows that, centers that do better are centers that not only get fewer complications, but they're ones that are able to treat the complications successfully. So the steps of kind of along the way to getting the best outcome of your transplant starts with the transplant. It starts with the patient. It starts with the selection. It starts with the donor. It starts with the surgery. But if you said, what is the long-term kind of outcome, that really hinges on your long-term care plan of your doctors at home, your family, your ability to take care of yourself. And then also kind of the long-term follow-up and the careful kind of balance between too much immunosuppression and not enough immunosuppression. And that's things that take years and years to kind of describe and years to tease out of data. But if you said, what do you want? You want someone who gets just the right amount of immunosuppression. And how do you find that? It takes a lot of challenges to do that. All right. So propionic acidemia transplants, and this is again worldwide. So realize that every patient, and when you look at this data, realize that every patient with PA is a little bit different. Maybe not every patient, but there's certain subclasses of patients that have different mutations. And like I said, the genes that are there are not just in the liver. And so I'm only doing enzyme replacement. And so, every patient is not the same. Not every center is the same. And so that kind of makes this data a little bit trickier to understand. And so this is the most recent paper on liver transplant for propionic acidemia. It came out of Hungary. I never thought I'd say a paper out of Budapest, but there it is. And so they published the worldwide results of liver transplant for propionic acidemia. The red line is the United States general population mortality. And it's a little bit confusing, but what they did was they looked at the treated and untreated patients. This line is only the treated patients, and these patients who had liver transplant. I mean, you can see that even with a liver transplant, your survival long term, and that's a very, let me see one second. That's 100 years that spanned out over there. The survival is clearly not the same as the United States. And so just like we said, we can treat the disease, we can treat it, but we're not going to cure it. And I think that it's a humbling slide, and the data is not perfect, but I think that it does point to the fact that we can treat it, but we can't cure it. And so this is the biggest study that was done in 2021. It was a review of 21 papers on pediatric liver transplant, a thing called a meta-analysis. And they looked at all of the papers that had been presented and all of the papers that are out there for liver transplant with PA. It's 70 patients, which is it's a huge experience. And again, it's multiple centers, some small, some large, but the results overall are pretty good. And so I think that the short-term survival was really quite good with these. But it's important to understand that some of the complications and some of the things stick out. And so number one was the cardiomyopathy. And when we say, oh, let's talk about cardiomyopathy and it's a rare disease, and you talk about PA and it's a rare disease, in this entire study, there were 11 patients with pre-existing cardiomyopathy. And so it's hard to really make any sort of educated statement on the ability of liver transplant to reverse cardiomyopathy based on 11 patients. That's actually even harder. It's hard to really make a huge statement on 70 patients, but 11 is even worse. None of these patients had progressive cardiac disease. And when this paper came out, I think it came out in 2021, it was, wow, this is good evidence. This is great. And all is well. And then Dr. Berry, almost immediately after this paper came out, published a report of a patient who had a transplant for propionic acidemia and developed recurrent cardiomyopathy 3 years later. And so there's no question that this can happen. And I think that although the gene data for patients in study 1 were not really available, so I can't tell you the exact mutation, the exact problem that they had, I think that you can do liver transplant for cardiomyopathy. It in many patients, it seems to stabilize, but it's hard to refute evidence, and it's hard to refute things when there's been reports of patients who have had recurrent cardiomyopathy. In this paper, actually, they discussed also 4 other patients who were transplanted for propionic acidemia, 3 of whom died in the early post-transplant period. And they said, well, lo and behold, clearly, these patients, it wasn't cured. But if you really think about the kind of mechanism behind damage of propionic acidemia to the heart, it wouldn't be expected. And these are patients that died in the 30 days after liver transplant. It wouldn't reverse it anyway. And so I think that, a little bit of that was not at least a fair statement about liver transplant and cardiomyopathy. And so what's the Children's Hospital experience with PA? And so we published, the diagrams that I had with the various biomarkers were not real biomarkers up there, really came from that study. It was only 3 patients at the time. But I looked through, and since the publication of that paper, we've actually done a fair number of liver transplants, and so we have 9 patients that we've transplanted for PA. All of them remain on protein restricted diet, so they're on. Transplant is not going to completely reverse things. All patients are still alive. We'll talk about that in a second. No patients had a metabolic crisis after transplant. Now, when I say metabolic crisis, I mean real metabolic crisis. Certainly, patients after transplant get admitted for IV fluids. Patients come in for, and at the time, if you measure things like ammonia levels, their ammonia levels are mildly elevated. PA patients and MMA patients after transplant, we are much more prone to admit for minor issues, viral infections, that type of thing. So there's no question that after a transplant for an organic acidemia, you're much more likely to be readmitted for hydration for these type of things, just because it's not a completely curative disease, not a completely curative treatment. But no question, but we have not had a major metabolic crisis in our patients. Only one of our patients had severe cardiomyopathy, or relatively severe cardiomyopathy at the time of transplant. It was actually the first patient we did. And they actually reversed a lot of their findings on echo at 2 years out. They are now 7 years out and have not had a recurrent issue with echoes. They've had echocardiograms and their echocardiograms have remained stable. But I'm not, but if 11 patients in the entire study that was a meta study, really, I can't say anything based on one patient. We also did a transplant in a 20-year-old that had mild cardiomyopathy years ago, and he overall has done well, and his cardiomyopathy hasn't progressed. He lives in Brazil, and the only follow-up that I have really is that he's doing well, but I don't have any echocardiograms in the past couple of years. And so our total number of patients is here. It's 11, and you can see I can't even read that much. And so the median age is about 2 years. We had patients that get all types of livers, and so as you can see here, I'll go for that side of the room. Only one patient got a whole liver. And so that's important to kind of understand that most of the patients got split livers. We did do living donors in two patients, and two patients got what they call a domino liver transplant. And so we took a liver from a patient that has a disease called maple syrup urine disease. I'm mixing my organic acidemias, even though that's not really one. But I think that and it was a curative procedure, worked fine as far as enzyme activity, and they've had good results with that. And so what is something on the bottom? Yeah, median hospital day is 20 days. And so most of the patients were out of the hospital. One patient went home on day 11, and then another patient was in for 100 and something days. And that was actually the patient with the cardiomyopathy. Complications. We had one patient, also the patient with the cardiomyopathy, who had a intrahepatic hepatic artery thrombosis. And so 1 out of 10. There has been a lot of talk about hepatic artery thrombosis and propionic acidemia, that there's a higher rate. I don't think so. I mean, I think that anytime you're doing a liver transplant in a small baby, there's an increased rate of this, and certainly patients who have poor cardiac output, patients that have other diseases that cause things like low blood flow, will have an increased risk of hepatic artery thrombosis, but I don't think it's a real issue. 2 patients had biliary strictures, and a few patients had wound complications, which is not unexpected, again, in this population of patients. One patient did die, oddly. One patient died at about 28 days after her pediatric liver transplant. She actually developed disseminated herpes and passed away in the pediatric ICU. And so I think that that is something that is not related to the transplant, other than it's a complication of immunosuppression and a viral infection. And so the patients right now, we have about 249 days of follow-up, 2,049 days of follow-up on these patients, and we have right now all of the other patients are alive with functioning grafts. And so, really, in summary, PA is a complex disease. It's a unique disease. It's a kind of a diverse disease in its presentations. It's not the same disease amongst everyone, and really, I think that liver transplant represents an enzyme replacement in the blood. Again, that's the best way to think of it. It's certainly been done. I think the complication rate and the risk associated with liver transplant for this disease is perfectly acceptable. I don't think that children have increased rates of complications over other diseases, as long as they're well selected. And the same with the adults. I think that any patient that you're doing, if you select well and select the donor well, you'll have an acceptable outcome. And so I think that is one of one of the things to think about if you're thinking about pediatric liver transplant for this disease. The cardiomyopathy, it's a major hurdle. It's oftentimes thought of as an indication for the liver transplant. I think you really, I can't say for sure that the disease will be cured by a liver transplant based on 11 patients, especially when there's a disease, when there's a report that it did recur afterwards. It does offer some stability in the disease, and from a overall mechanistic standpoint, it does make sense that it might get better, but I don't think that I would say, hey, liver transplant, for patients with PA with a cardiac issue, it's just they're going to get better. I don't think we're there yet. In addition, and I would say that also and I didn't put that in there, but I think that for neurologic issues, there have been reports of patients that have had crises after liver transplant. There was a report out of the UK of a patient who had a metabolic stroke. I think it was 10 years after a liver transplant. It was a living donor liver transplant using a mother. And whether that enzyme activity is less or not, I don't know the answer to that. But I think that patients that have transplants for PA need to be followed very closely after transplant. And again, it's a treatment and not a cure. I think that was that's it. And so I'd be happy to take questions if you have them. Yeah. What is it? So you would take a piece of just like you do the deceased donor, where you take that little piece of liver for a child. You would take it out of someone that's living and put it into somebody that has this disease. And so you could do it from anybody to anybody. You can do adult to adult as well. The donors do very well. There's not the donors, the piece of liver that you take isn't enough so that they would miss it. It has been done. Since you asked, it has been done in Japan. There's a lot of good reports about this, actually, from parent to child. And again, I'm a little leery about the disease. The genetics at least is known here in the Japanese study, but these patients did very well after living donor from parent to child. But that's something that I don't know the answer to that. Anyone else? No other questions? My favorite color is blue. No? Yeah. Yes, that's a good question. Do I keep the livers for research? Yeah, so the livers that are taken out oftentimes are used and they're processed into liver cells. And those cells are used to power a lot of research in the United States. So yeah, and in many of the diseases actually that we transplant. Yeah, that's good. No, yeah, I think the enzyme system there, it actually MMA livers have been used. I don't know the long-term outcome of those. So that'd be a good question for Dr. Venditti.
The recipients have methylmalonic acidemia.
But besides that, they're fine.
I'm ready to say yes to that.
I'm kidding. I wouldn't. I've never done it. And what do you think about parent as donor?
I know, based on our experiences and your experience, have some in the room. A living-related donor transplant for the liver. Fine. Carriers don't have any biochemical.
Right.
Study this expensive.
Yeah. So you mentioned the time window of like 6 to 8 hours to arrive for transplant.
Yeah.
We're like 5 to 6 hours.
No problem at all. Yeah. We've had patients come from California, Puerto Rico, all sorts of places to get their liver transplants. We help with transportation. And again, I think that the driving distance is not a problem at all. If it's having just done the drive and having to do it tonight, not a problem.
What would be kind of the maximum distance for family to want to fly?
Oh, I mean, I think a 12-hour drive is fine. I mean, I think that what we try to do is the way it works in reality is that you get called with an organ offer as a potential match. You then call your recipient, and then the donor time is set, usually based on the heart team. And so they try to figure out a time where everyone can do it. patients with PA and metabolic disease oftentimes come in and you have to make sure that they're stable and make sure, and so it takes a bit of time to get them completely ready for transplant. But I think, 10 hours, you could always slow down the donor time. Yeah.
Safer to do a partial transplant versus
Yeah, it's a good question. I think that so if you look at the results at centers that do it, the results are the same: living donor, split liver transplant, whole liver. And so I think that now you can say that 15 years ago it was a little bit different. The techniques that you did for split liver transplant weren't quite as good. I think the best long-term outcome is living donor. And some of that is because you transplant the patients earlier, and that's all comers. And so patients that have liver disease, if you can transplant them early, they tend to have a better result because they weren't as sick. It may be the same with a disease like PA, so you would avoid crises, that type of thing. But there may also be some immunologic benefit if it's apparent, because they're half of your, half of the antigens, half of the things that your immune system recognizes are the same. But it's likely. So I would say that if you said what's the best long-term survival, it would be living related, and then behind those two would be either one of the two, split liver or whole. Yeah.
results are about the same.
Yeah, all of the results. I mean, we're talking about over 10 years, you would talk about a percentage point here and there, and it's not the results strikingly are have become almost equivalent. Yeah.
Difference between transplant in like the neonatal and infancy period for livers versus pediatric versus adults, like there is
there's no, so under a year of age is considered higher risk at some centers. It's more, it's not so much the risk profile, it's more the source of organs. And so it's very hard to find a liver that is an acceptable size for somebody that's under, say, 6 kilos, 7 kilos. But I think that in that weight range, 7 to 10 kilograms, the complication rate is about the same as it would be for somebody bigger. And again, it depends on what center and that type of thing. But I think if it's a center that's doing a lot of pediatric liver transplant, it's about the same. There was a question over there, I think. No. There you are. Yeah, so I think that an early transplant would maybe not prevent cardiomyopathy, and so I think that a transplant for prevention of crises and prevention of metabolic decompensation is, I think that at an age range of a year of age would be the time where I would say the kind of risk and ability to get liver is about right. I can't say that it would prevent cardiomyopathy. I wish I could, but I 11 patients, 10 patients, and that I just can't say it. And with a recurrence years after transplant in one study, I just, there's nothing you can do. So could it make it better? Will it make the disease process better? Will it make it easier to manage? Yeah, it'll help with the metabolic derangements and everything else. It'll decrease your crises. But I think from a pure standpoint of the heart being separate from the liver, it's just not there yet. Anyone? All right. Thank you.